Wow, cardiovascular is long, and that is because there's a lot of physical findings. It's not like nephrology. You got about 2 physical findings in the entire specialty, which is you have renal artery stenosis, bruits, and edema. It's not like hematology where you have petechiae and pallor. No, cardiovascular is a physical finding specialty. So you could think of this section as your companion for physiology. When we do skin, it's your companion for pathology and also microbiology as well. So here, this is the cardiovascular physical finding companion set for the step 1 physical findings of physiology, and that also includes pulmonary physiology. Now, hand grip in the cardiac maneuver, I'm putting this again in a special card because often students need this repetitively, that hand grip and amyl nitrate are the opposite of each other. Hand grip increases afterload, amyl nitrate decreases afterload. And the effect of these on the heart is that hand grip is like the opposite of an ACE inhibitor. Amyl nitrate is like an ACE inhibitor. And the effect of these on the murmurs are what they do about increasing or decreasing the loudness or intensity. Hand grip is going to increase afterload. So an increased afterload as you press firmly and squeeze a hand, you give them something to grip. Basically the muscles of the upper extremity compress the arteries. And when they compress the arteries, it increases afterload, makes it harder for blood to get out of the heart. When it makes it harder for blood to get out of the heart, it makes regurgitant lesions worse. Now, there's no significant effect on venous return. This is the #1 most common wrong answer. The most common wrong answer is thinking that hand grip is like squatting. Now, squatting increases venous return because thighs are big. Look at the size of your thighs. So the thing is that hand grip doesn't do that because the volume of the triceps is much smaller than the thighs. The other thing is your arms are already draining into your heart most of the time, so they're not filled with blood. You can't bleed to death inside an arm. In other words, a fractured humerus doesn't have enough volume to result in death. A fractured femur does. So a fractured femur, you can basically die by bleeding out into your thighs. Motor vehicle accident, bilateral femur fractures. Oh, it's horrible, man. It's horrible, horrible. You could put a liter in each thigh. It's terrible. I don't even like thinking about it. Like, I'd gross myself out. I hate that. I was going to get rid of all death because I just can't handle it. It's just disgusting. So the thing is, though, there's no effect on the heart of hand grip in venous return. Not in venous return because the veins are just smaller than those of the legs. Now, amyl nitrate is an arteriolar dilator. It's a smooth muscle dilator. Nitrates are smooth muscle dilators. That's why we use them in coronary disease. That's why we can use them in Prinzmetal's angina. That's why we use them in Raynaud's sometimes. That's why we use it in esophageal spasm. We use it in esophageal spasm because nitrates are a smooth muscle dilator. And when you do a smooth muscle dilation, it simply dilates the vessels, and so forth. It increases the size of those vessels, therefore decreasing afterload. It's like giving an ACE inhibitor. So since it decreases afterload, regurgitant lesions diminish with amyl nitrate, and regurgitant lesions increase with hand grip. Period. And that's it. Hand grip will lessen aortic stenosis because when you increase the pressure in the aorta, blood can't get out, and you decrease the murmur of aortic stenosis by making the aortic pressure higher. ACE inhibitors improve regurgitant lesions. Hand grip worsens regurgitant lesions, and that's all regurgitant lesions, no matter whose heart. So one love, baby. Same love, same love. Okay, our next slide is hypertension. That's not a physical finding. Of course it's a physical finding. What do? Find it on astral projection? Yeah, hypertension is one of the most important of the physical findings. Who should be screened? We're not really sure, but we say every visit starting at the age of 18, so all the time. Now, this thing about defining hypertension, this is a slide that actually changed recently. So if what I'm about to say disagrees with books you're reading, it is because the video, what we're doing now, is more current. Because it's easier to fix digital video. Therefore, this stays more up to date than up to date. That's right. So the definition is different in the general population because what is it in diabetes? And basically, what is the cutoff in renal disease? And here, what do you do to start initial therapy with 2 medications? So the change of this is that in the general population, the cutoff for blood pressure is 140/90. We do not teach to the concept called pre-hypertension because we're not sure what that means. We're not sure what to do about it. And everybody should exercise and eat right and lose weight and stop smoking. So it's not particular to pre-hypertension. It's like not yelling at your mother. You know what I mean? It's not just because you have pre-hypertension. You're not supposed to be doing that. So the hypertension is defined as 140/90. And now here's something that may differ from some of your books. That is a change in the not too distant past, because it used to be 130/80, now, and then 130/85, now 140/90. Turns out that you didn't need a special lower cutoff. Now, ACE inhibitors are the therapy for when you have a diabetic, ACE or ARBs, in diabetic hypertension. And the hypertension, of 130/80, the lower cutoff does have some value when you have hypertension causing renal disease, when we really want to protect the kidneys. Most likely thing is that USMLE is not going to ask you anything controversial, so they're not going to get in your face about things like the blood pressure cutoffs for diseases where it's a bit controversial. So therefore, the cutoff in diabetes in the general population, 140/90, and maybe 130/80 for people who have renal disease. Now, when you have really severe hypertension, 160/100. When you have really severe hypertension, like 160/100, what you have to do then is you start with 2 medications. You start with 2 medications when you have very severe hypertension, because one medication is highly unlikely to be able to ever control a blood pressure of 160/100. It's very, really unlikely that you'll get one blood pressure medication to control it, so use 2 blood pressure medications when it's really high. What are these things? What is it? The most accurate test? And how do these physical findings change management? Ooh, splinter hemorrhages, Janeway lesions, Osler's nose, Janeway lesions. And what are those? They are not Roth spots. Roth spots are in the retina. Roth spots are in the retina. Roth spots are in the retina. So since Roth spots are in the retina, those things that look like subconjunctival hemorrhages, you know what they are called, these things that look like subconjunctival hemorrhages? They're called subconjunctival hemorrhages. And all of these are findings of endocarditis. Splinter hemorrhages in the fingernails, Osler's nodes raised and painful, Janeway lesions are flat and painless, and these are the embolic findings of endocarditis. All of these things. Well, it looks like a multiple choice question, but the answer is all of them. Okay, they're all found in endocarditis, as they're saying what's in picture A, picture B, picture C, and with positive blood cultures. The blood cultures are first. This is a photograph of the veggies. Those are the vegetations. Those are the vegetations that would be found in endocarditis. So the vegetations of endocarditis are embolic phenomena, and how they change management is not in most people. If the blood cultures are positive and you have vegetation, if you have blood cultures positive and you have vegetation, if you have blood cultures positive and you have vegetation, if you have blood cultures positive and you have vegetations, it doesn't change anything. because you still need to give 4 to 6 weeks of antibiotics. You still need the blood cultures to be negative. It doesn't change anything. They're not an indication for surgery unless they continue to happen while on antibiotics. They're not a change only if they continue to happen. Now, a small number of people, 1%, 5% of people, have negative blood cultures, a small number. So they can be useful to help you diagnose. They're useful to help you diagnose people with endocarditis in the small number of people who have culture-negative endocarditis. So in those people who have culture-negative endocarditis, okay, small number of people, okay, what you do is a fever, a risk, a fever, a risk, and embolic phenomena, emboli, fever, risk, fever, emboli, emboli, fever, risk. Those three things together and a vegetation on the heart valve can be the diagnosis of endocarditis. So these embolic phenomena can be signs of endocarditis, and they make a difference if they continue to happen while on antibiotics or if the cultures are negative. The other reason they make a difference is so you have to identify them on step 1. Cardiovascular. What is that? Looks like jugular venous distension. What's it associated with? Congestive heart failure. This is cardiovascular section, and you don't know the answer? Say echocardiogram. What do you do when you have jugular venous distension? You're so filled with fluid. Let's diurese you. It's jugular venous distension, and it's a sign of congestive heart failure and valvular disease, all of them. All valvular disease can present with jugular venous distension and CHF, so all congestive heart failure, and it is just a sign of all things that make it hard for blood to get back into the heart. A tension pneumothorax and constrictive are rare causes. All of these, tension pneumothorax and constrictive, can all do it. These are all do it, as well as tamponade. They're rare, but they do cause congestive failure and jugular venous distension. Much more common, out of control CHF. Now, the most accurate test of the heart, generally speaking for this, is going to be an echocardiogram. Catheterization not necessary. Now, the treatment is based on the cause of these, and so for almost all of them, the answer is a diuretic. But it's a good sign of asking you, do you understand the anatomy for step 1? That's why you got to know about it. You got to know about it because it says, I need to be able to understand the anatomy for step 1, USMLE. Complex level 1. What's the difference? Is there a different blood vessel in complex? Like osteopaths have like 6 extra vessels or something? I don't think so. So saying the jugular veins going into the subclavian and innominate and subclavian into the superior vena cava. So see, jugular venous distension can be a anatomy question. Oh, jugular vein. Ooh, facial vein draining into it. It's the anatomy question, okay? The anatomy question, that's what it's for. It's a test of anatomy. Kussmaul sign, what's that? Kussmaul got around, didn't he? Kussmaul breathing, Kussmaul sign. Kussmaul was a contemporary of Charcot. Kussmaul described polyarteritis stenosa too. Kussmaul. So he was a very prominent guy actually in his day. And Kussmaul's breathing is fast, rapid breathing. That's like diabetic ketoacidosis. Okay, Kussmaul's breathing. Can you imagine a guy described heavy, deep breathing and he put his name on it? So he saw 2 people getting laid and he's like, you two. That's my breathing. Kussmaul. Every time someone breathes like that, that's my breathing. Wow, that's amazing, really? So what's the Kussmaul sign? The Kussmaul sign is most likely to be associated. This Kussmaul sign is a jugular venous pressure finding. Kussmaul sign is a jugular venous pressure finding. And Kussmaul sign is associated with a pericardial disease. And the most accurate test of pericardial disease, if it's anatomic pericardial, is a scan. Kussmaul sign is an increase in jugular venous pressure on inhalation. It's an increase in jugular venous pressure on inhalation. That's what Kussmaul's sign is. Now, Kussmaul's breathing is deep, heavy breathing. Normally, jugular venous pressure should jugular venous pressure when you inhale. Oh, you know what happens? Is that normally what happens to jugular venous pressure when you inhale is that the decreased pressure in the chest, the low pressure in the chest, should literally suck blood into the heart. The low pressure in the chest should suck blood into the heart. But when your heart is encased, has your heart grown so small? Like the Grinch who stole Christmas. Should have a heart 2 sizes too small. But that's what Kussmaul's sign is. Kussmaul's sign is the Grinch, man. It's like a guy whose heart is 2 sizes too small, encased in a stiff pericardium, that when you inhale, the normal jugular venous pressure should decrease, and now here it increases and goes up. That's the abnormality. Kussmaul's sign is associated with constrictive pericarditis, which is like wearing underwear 2 sizes too small. And on inhalation, what happens is that the tight pericardium doesn't allow for blood to return to the heart. Rises. Doesn't allow for blood to return to the heart, so the pressure rises. The most accurate test for the constriction is to scan the heart, because constrictive pericarditis is a sign of an anatomic abnormality of the heart where it is encased abnormally, and that anatomic problems are diagnosed with anatomic tests. The thickened pericardium, the thickened pericardium, the thickened pericardium that calcifies, there's the heart, there's the heart. There's the thickened pericardium that calcifies. Ooh, there it is again. Fantastic. So here's the anatomy and pathology questions. The anatomy and pathology of constrictive pericarditis is being shown by X-ray. So Kussmaul's sign clinically? Kussmaul's sign for understanding the physiology. Decreased intrathoracic pressure normally pulls blood into the heart. Abnormally, builds back up here. Pathology, calcification, most commonly tuberculosis. Anatomy, where is the calcified pericardium? How do we test the anatomy? Imaging scans, imaging and scans, imaging. Oh, I'm having fun. So, allowed P2. Oh, screw off. Don't bugger off, man. Don't make me learn this stuff. Well, allowed P2 is the second component of heart sounds. The P2 is a second component of heart sounds. So when the allowed P2 is described, what's the diagnosis? In the care, the most accurate test. Well, it's a cardiac thing, so it must be echocardiogram. Looking for cardiac things, loud P2, extra loud, second heart sound, like slamming the door. Slamming the door. Is slamming the door, it's from pulmonary hypertension, man, because the second heart sound should be made up of the aortic sound and the pulmonic sound, the aortic sound, the pulmonic sound, and when you have an extra high pulmonic pressure, it slams that door and you get a loud P2. So the second heart sound with the loud P2 is a sign of things like pulmonary hypertension, pulmonary artery hypertension. Mechanism. Endothelin overgrowth, there's the pharmacology. Endothelin antagonist, ambrisentin, bosentin, ambrisentin, bosentin inhibits endothelin in the pulmonary artery, because pulmonary artery hypertension gives a loud P2. Now the etiology is pulmonary hypertension from multiple pulmonary emboli, clogging me up. Mitral stenosis, but that's on the left side of the heart. Yeah, but the final destination of the right heart circulation is the left side of the heart. The final destination of right heart circulation is the left side of the heart. Back pressure, back pressure, back pressure. All these are saying back pressure into the heart. Where you hear things. Oh, APTM, aortic, say, Oh, aortic, pulmonary, tricuspid, and mitral. Sorry, I forget what side I am now. It's mirror image, right? Aortic, pulmonic, tricuspid, and mitral. Yeah, it's hard background, so I feel like scratching my shoulder by reaching through my fly here. Okay, so the point is where do you hear these murmurs? Where do you hear these murmurs? Okay, and that's the location, the anatomic locations. This is a must-know subject for this. Don't walk into step 1, step 2, or step 3 without knowing these. And step 4, which is the internal medicine boards. Well, also, let me give you the good news. If you get this now, you're never going to have to learn it again. And you may be thinking that because of the increased use of technology in the hospital that we'll be letting go of you needing to know physical findings, but it's not true. It's not true. Okay, so the increased physical finding knowledge, it's not going to go away. Now, I know very well, because I know how attendings round. They round from the doorway. They don't go to the bedside very much. Instead of saying, did you hear a loud P2? They go, yeah. What's the echocardiogram show? And I understand that. But you know, just because it's not done doesn't mean you don't have to know it. Wide splitting of that P2, wide splitting and loud P2, pulmonary hypertension, pulmonic stenosis, and the wide splitting right bundle branch block. Delayed emptying, delayed closing. And it's very close to the same things and more that make the P2 loud because it bashes the door. This is sign of pulmonary hypertension. Sign of pulmonary hypertension. You see the hilum, the blood vessels in the center of the chest, when they hypertrophy out both ways. And also, mitral stenosis can straighten the left heart border. Mitral stenosis can straighten the left heart border, can give a double bubble behind the heart, straighten the left heart border, double bubble behind the heart. And what happens with mitral stenosis is that the back pressure makes the pulmonary arteries extra big and prominent. And that connection of mitral stenosis making the blood pressure higher in the pulmonary artery is a must-know subject. Mitral stenosis increases pulmonary hypertension. Bang, the P2. Now, the loud S1. By the way, you know why they're called S1 and S2? It just means sound. Sound 1, sound 2. So a loud S1 is something, the loud S1 is in the stem, the diagnosis for loud S1 and the mechanism is. Well, remember a loud P2. When you had a loud P2, we said it was pulmonary hypertension, pulmonic stenosis, raising the pressure. Well, here, this is the sign S1 of tricuspid and mitral valve closing. So now an echocardiogram is always the most accurate test in anything in cardiology of the heart, anatomically, just about. So a loud S1 is something that happens. MDM means mid-diastolic murmur. Opening snap, mid-diastolic murmur. Opening snap, mid-diastolic murmur. Okay? So this loud S1 is something that can be caused with mitral stenosis because the pressure is extra high in the right atrium. In the left atrium. The mitral stenosis makes the pressure extra high. And also, anything that does a shortened PR makes the mitral valve close earlier or later. Short PR. Short PR. Short PR. The PR. Also, if you are looking at this material and you've not studied before, you remember that you can't review something you never knew. You should stop the video and go look it up, come back to it, because here we're condensing all physical findings for all diseases, and I mean all diseases, and I mean all physical findings. You mean there's only 200 of them? The truth is there's not even really 200 of them. Actually, when you go, I just picked 200 because it's a nice easy number. It's a nice easy round number. 200 tests, 200 physical findings, 200 groups of drugs. And there's about 200. So it means that you can learn all physical findings in all diseases, in OBGYN and in psychiatry and in cardiology, pulmonary, GI, in 200? Yeah, that's the fact. That's the fact. So, but a short PR, if you're not familiar with it, is things like Wolff-Parkinson-White. Wolff-Parkinson-White is a short PR. It's also called Pre-Excitation Syndrome. Now, a Pre-Excitation Syndrome means the ventricle depolarizes early or depolarizes late. Depolarizes early. It's a short PR, fast. So you see the mitral valve is already open, still open. Mitral valve is still open. So instead of the nice normal flop, flop, the ventricle contracts and goes bang, bang. That's why short PR causes a loud S1. Anything that causes premature closure, bang, bang. Things like mitral stenosis. The mitral valve is open, the ventricle contracts while the mitral valve is still open, and instead of the nice flap, flap, it closes with a bang, because the stenotic valve is still abnormally open. Here, mitral stenosis. Take a look. Can you figure it out? Well, the reason why the volume in the disease goes down, because the red is the diseased, is because it can't fill. So since it can't fill, it tends to move over. It's moving over. Okay? Can't fill. It can't fill. So the volume is less. Normal volume, diseased volume. Normal volume, diseased volume. Normal volume, diseased volume. It can't fill. Normal volume, diseased volume. Because it can't fill. So the left ventricular pressure is not up or down. It's the left atrial pressure that's up. But you can't fill, so it decreases cardiac output. Now, all valvular lesions present with shortness of breath. They can. All valvular lesions can present with shortness of breath. All valvular lesions. All valvular lesions give congestive failure. All valvular lesions can give congestive failure. But they don't all give a loud S1. Calcification and fibrosis gives a loud S1. And this slams that valve shut, making it close abnormally high pressure with an abnormally high pressure. The same thing in the short PR, it contracts prematurely while the mitral valve is still open. And that's why the most accurate test for all of these tends to be the echocardiogram. The mitral valve won't allow filling, so the left atrial pressure is up. The mitral valve won't allow filling, so the left atrial pressure is up. Now, it doesn't change the left ventricular pressure. LVP means left ventricular pressure, but the atrial pressure is up, and that's why we have all these illnesses, because the left atrial pressure is up, that dilates the atrium. Atrial pressure is up, dilated left atrium. Atrial pressure is up, dilated left atrium, more AFib. More AFib, more stroke. More dilation, more dilation, more AFib, more stroke. Dysphagia, because the left atrium presses against the esophagus. Dysphagia, as it presses against the esophagus and dilates. Oh, the opening snap, mid-diastolic murmur. Opening snap, mid-diastolic murmur. This is not going to go away. It's not going to change. One, you're going to have to know. Two, if you learn this now, you're never going to have to go back. You're never going to have to go back. And doesn't that help you explain why mitral stenosis has the most amount of dysphagia, enlarged, press of the esophagus, most amount of AFib, the most amount of stroke? Gets worse in a pregnant woman because the pregnant woman increases her plasma volume so much. All fits together, doesn't it? Opening snap and murmur. Next heart sound. What do you hear? So we have a 64-year-old woman who comes to the office. She's got exertional short of breath and hemoptysis. Well, that doesn't narrow it down. All cardiac valve lesion can give you shortness of breath. Hemoptysis tends to be something that causes it's from the cause of pulmonary hypertension. And a holosystolic murmur is heard. Holosystolic, that's the holosystolic. And what's the difference between holosystolic and pansystolic? Holosystolic and pansystolic. Holosystolic and pansystolic, and the answer is nothing. See, a holosystolic or pansystolic murmur is mitral regurgitation because it obscures both S1 and S2. Mitral murmurs go to the axilla. They go to the axilla. Carotids to the aorta, mitrals to the axilla. Okay? And the most common, that's where it radiates. That's where is it radiating. The most common cause is anything that dilates the heart. Dilated cardiomyopathy, hypertension and ischemia. Hypertension and ischemia, the most common cause. It's back to hand grip, Valsalva, and our old friends, the auscultatory maneuvers. But you can't intimidate me now, auscultatory maneuvers. I have mastered you. No me jodas, coños. Okay, so this is the failure of the mitral valve to close, so blood regurgitates backwards. The failure of the mitral valve to close, so blood regurgitates backwards. With the failure of the mitral valve close, it backflow into the left atrium. Backflow, very good, it dilates. Remember, dilation equals regurgitation. So mitral regurgitation or insufficiency, holosystolic, pansystolic are the same thing. Mitral regurg, mitral insufficiency are the same thing. It obscures S1 and S2. That's why it's called that's why it's called pansystolic. It's heard better when you're leaning forward. When you're leaning forward, you bring your heart towards the chest. You bring your heart towards the chest. You bring your heart towards the chest, and you hear it more. And it radiates the axilla as regurgitant murmurs do. Here's a different representation. Pause and absorb. Oh yes, obscuring S1 and S2, and this is the extra left atrial pressure. Sure, it's extra left atrial pressure because it's regurgitating backwards. Look, it's extra left atrial pressure because it's regurgitating backwards. There's extra. 10, 25, 10, 25. It's regurgitating backwards, extra left atrial pressure, dilated cardiomyopathy, AFib. So anything that causes you to kill off the heart, it gets wider. Ischemia kills off the heart, gets wider. Endocarditis makes the valve incompetent. Incompetent valve overstretches. Rheumatic fever can cause any of them. Rheumatic fever is very rare in the United States because we treat all these throat infections with enormous amounts of antibiotics. So therefore you will see very little rheumatic fever. So rheumatic fever is basically, although it causes any of them, it causes mitral stenosis the most often. Mitral valve prolapse regurgitates, but when it's from prolapse, you have different symptoms. That's basically chest pain and palpitations. But remember, the prolapsing heart valve, when it doesn't fit together, the prolapsing valve is incompetent and it regurgitates. Oh, hand grip increases the afterload. You squeeze the arteries of the arm and it shoves the blood backwards. Hand grip. The opposite of hand grip is amyl nitrate, which dilates the arteries. So hand grip is the opposite of an ACE inhibitor. Amyl nitrate is the same as an ACE inhibitor in terms of amyl nitrate vasodilation, and decreasing afterload. So amyl nitrate softens all left-sided murmurs except mitral valve prolapse and hypertrophic obstructive cardiomyopathy. Valsalva decreases venous return. Less blood, less murmur. Increased intrathoracic pressure decreases venous return. Squatting does the opposite of Valsalva because when you squeeze the leg veins, squeeze the leg veins, you are increasing venous return because your thighs are bigger. This is not repetitious by accident. What do you hear? Oh, we heard a pregnant woman having more shortness of breath. Let's hear, okay? Hear that as many times as you want. It's a very complicated murmur because it's a diastolic, mid-diastolic murmur. Pregnant women increase plasma volume. The increased plasma volume worsens a couple of things. It worsens stenosis the most. Hemoptysis is a sign of pulmonary hypertension. Telling you that she's an immigrant to the United States from places with less health care means rheumatic fever. This is the opening snap, and this is the mid-diastolic murmur. Opening snap, mid-diastolic murmur as the blood squeezes through the heart. It's an immigrant, meaning to tell you rheumatic fever is an imported disease. If you can afford a few pennies for penicillin for your kid's strep throat, you won't have rheumatic fever and you won't have mitral stenosis. Now, this is mitral stenosis murmur, and it's most likely caused by rheumatic fever because almost nothing else will do it. That's why we'll give you an immigrant. All valvular disease causes shortness of breath. All valvular disease causes edema, dyspnea on exertion, jugular venous distension. That's all valve disease. But all valve disease does not have dysphagia, hoarseness, and all that strokes. Valsalva decreases venous return. Squatting increases venous return. Less blood, less murmur, more blood, more murmur, except HOCM and mitral valve prolapse, which are the opposite. What will happen to the extra heart sound, okay, the opening snap, as this worsens? Does the opening snap happen earlier or later? The opening snap, what's going to happen? The opening snap, look at the timing of the opening snap. Will it happen earlier as it gets worse or later? What opens the valve? What opens the valve is pressure in the, this is the mitral valve. What opens the mitral valve is pressure in the left atrium. When the disease gets worse, does left atrial pressure get worse? Yes, it do. Worse disease, it opens earlier. Look, mitral stenosis has an opening snap, and that opening snap happens earlier when the disease gets worse because left atrial pressure goes up. Now, mitral stenosis is most likely from rheumatic fever, which causes fibrosis. That's why you can balloon it. You can balloon it because it's fibrosis. You can balloon it because it's fibrosis, and that's why it pops. You can't balloon aortic stenosis because it's calcification, it's sheetrock, it's bony. But mitral stenosis is fibrosis, and the fibrosis can stretch. If you're a guy and your mother sends you underwear that's 2 sizes too small, what would you do with it? Men don't return clothes. What do? You probably give it a stretch and wear it. Too fibrotic. Underwearoplasty. And that's why here, mitral stenosis, you can balloon it. Now, here, massive enlargement of the left atrium. Big massive enlargement of the left atrium. That gives pulmonary hypertension. Pulmonary hypertension gives hemoptysis. Massive enlargement in the left atrium gives you AFib. More AFib, more emboli. More AFib, more emboli. Big atrium presses against the esophagus. Dysphagia. Pressing against the recurrent laryngeal nerve. You see, you get this once now, you're never going to have to learn it again. It's going to stay permanent, and you're never going to have to come back this way again. Valsalva decreases venous return because increased intrathoracic pressure, exhalation against the closed glottis. I just soiled myself. And squatting increases venous return, more blood, more murmur. Less blood, less murmur. Except HOCM and mitral valve prolapse. So as the mitral stenosis worsens, the opening snap happens earlier. And it happens earlier because the left atrial pressure goes up as the valve lesion worsens. Echo, cath, balloon. What do you hear? Young woman with the click. Most of the time she's not too sick. Palpitating, levitating, and a mid-systolic click. Palpitating pain and panic attack. Palpitations, and the answer also is just found. It's just found. What caused most mitral valve prolapse? Mitral valve prolapse is a 1980s disease, really. It's like big hair bands. Here I go again on my own. You know, you know what I mean? It's like, I don't want to insult Kiss, but it's sort of like that, you know what I mean? But the thing is, mitral valve prolapse was invented by the echocardiogram. Once we invented echocardiograms and they became everywhere in the 1980s, everybody got mitral valve prolapse, because it turns out that mitral valve prolapse, with that click, was asymptomatic. And then you got palpitations, and it's like young ladies with palpitations, and you found the click, and you found the mitral valve prolapse. And mitral valve prolapse, most of the time, is just the normal anatomic variant, and most of the time it's not symptomatic. If it's not symptomatic, don't do anything about it. Okay, all mitral valve prolapse, like all regurgitation, is heard at the axilla, radiating. Okay, heard the apex going to the axilla, 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 apex going to the axilla, because it's regurgitation. Now, the most common presentation, well, most people are asymptomatic, but when you are symptomatic, it's palpitations and what's called atypical chest pain. Typical chest pain is I go walking, and ay, Dios mío, ay, doctor, ay, yo tengo mareo, ay, que lástima, ay. That's typical pain. Atypical pain is, how you doing? I feel fine. And you just have pain. Typical is on exertion. Atypical is just happens. Atypical pain. Atypical pain. It just happens. You don't know which question you're going to be asked. And so the point of this methodology is it's very important that you understand that you have to be prepared for any one of these questions. That's the point of what's writing here. If they ask you this presentation, diagnosis, mitral valve prolapse. Cause, you say idiopathic most of the time, myxomatous generation, loose and floppy valves. The presentation, asymptomatic, and what is symptomatic, palpitations and pain. The auscultatory maneuvers can be difficult because for mitral valve prolapse and HOCM, it's the opposite effect of all the other valve lesions. Hand grip will actually make it better because hand grip prevents blood leaving and makes the heart bigger. Anything that makes the heart bigger makes the valve fit together better. There are some sources in places that are incorrect. They say the opposite. I forgive them. I forgive you. Mafkia, 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 bapu. Okay, I forgive you. Hand grip tends to improve it. Valsalva makes the heart small. Anything that makes the heart small, it gets worse because the leaflets don't fit. Squatting makes the heart big. Bigger heart makes them fit. Amyl nitrate increases dilation, makes it dilate. Arteries dilate, makes the heart smaller. This will become clear in a second. Do you need to use endocarditis prophylaxis? Actually, it may seem oddly out of place here, but I just happen to know what one of the most frequently asked questions are, which is that you should know that, you know, and you don't need endocarditis prophylaxis anymore with mitral valve prolapse. You don't need it, just don't need it. No matter what procedure you're undergoing, you don't need endocarditis prophylaxis for mitral valve prolapse. And it's just a very common question, so let's not screw it up, okay? So here's our friend, the heart, and a prolapsing valve means extra floppy, extra loose tissue. Prolapsing means it's floppy and going backwards. See, when the ventricle contracts, it's floppy and goes backwards. And the mitral valve prolapse, the click is the sound of those leaflets stopping short. It's the sound of those leaflets hitting and going pop, stop, click, click, click. And sometimes, if it really doesn't fit together well, it'll leak and that'll have regurgitation. So you just get extra floppy valve leaflets. Now, most of the time it just happens, and we don't know why. So like all regurgitant lesions, it's heard at the apex and radiates the axilla. This is prolapse. It's flopping backwards the wrong way. See, the ventricle's contracting, and the leaflets are going the wrong way. The ventricle's contracting, and the leaflets are going the wrong way. And it's billowing out there, and then they see the space. That's what makes them leaky and regurgitant. The click is when the leaflets stop short. Anything that makes the heart smaller makes them not fit. Anything that makes the heart bigger, they fit. Small heart, they don't fit. Big heart, they fit. Let's try it again. Small heart, they don't fit. Big heart, they fit even nice and evenly. Small heart, leaky. Big heart, tight. That's why the maneuvers are the opposite of all of the others. Now, palpitations, atypical pain. Remember, typical is on exertion. Atypical just means anywhere. Why has it been associated with anxiety? So it's not even clear. It's just a testable association. And most of them are, in fact, asymptomatic. The smaller the heart, the worse it is. The bigger the heart, the better it is. Valsalva and standing make it smaller. Valsalva and standing, by decreasing venous return, worsen it. And the click gets worse. Small heart, click worse. Nice picture, huh? Oh, look, there it is. That looks like the prolapsing valve, doesn't it? God, I love it. Looks nice. So the click happens later when the heart gets smaller. Squatting, which increases venous return, does the opposite and makes it better. Amyl nitrate makes ventricle empty more. Anything that empties the ventricle more, makes the heart smaller. Small is leaky for prolapse. Smaller is leakier for prolapse. And endocarditis prophylaxis, it's just not needed because you have very low risk. And this is a fantastic picture of the murmur of mitral prolapse that basically, okay, when you put the leaflets, the smaller or bigger, it changes the effect when you have a smaller or larger heart. Let me get out of your way, and I'll see you in the next section.